Hi, I'm Dr. Dean. I'm an eye surgeon working in Nelspruit and Mbombela, and today I'd like to talk a little bit about diabetic retinopathy, especially the management of severe diabetic retinopathy. So just generally, the basics of what happens in diabetes is a microvascular disease, meaning that it affects the small blood vessels of the body. The eye is quite unique in that it's part of the body that we can literally look at. The small vessels in your feet and your kidneys and your heart and in your brain are difficult to see. You can use angiograms and other ways of looking at those blood vessels. But in your eye, we can literally look at the blood vessels and see the state of them and what's happening and what the pathology is. So it's often quite a good window into what's happening in the rest of the body. And what happens with diabetes is the endothelial cells, which is the cells on the inside of the blood vessel walls or the arteries and veins, becomes damaged by sugar, normally over a long period of time. And what happens is, as those blood vessels become damaged, they stop functioning, they get blocked, and you get ischemia. And ischemia is essentially the word we use for lack of oxygen. So your retina becomes devoid of oxygen. And what happens is your body produces factors that try and encourage new blood vessel growth. It's normally a good thing to grow new blood vessels. Other parts of the body, for example, in your kidneys or your heart, if new blood vessels grow, it allows new blood flow to that area. It's a normal function of your body. The problem in the retina is these blood vessels grow along the surface and also into the gel of the eye, and they are abnormal blood vessels. They break, they bleed, and they result in scar tissue. So this process starts to occur when new blood vessels grow, they break, they bleed, they cause scar tissue, and where they cause scar tissue, they cause some traction, the retina starts to lift. And this starts happening in multiple places, and so you get a mixture of what we call traction, where the retina is starting to be pulled up, as well as areas where there's bleeding, either under the retina, into the retina, or into the gel, which we call a vitreous hemorrhage. And so as that process happens, the vision deteriorates further and further. And we never want to get to that situation. This is called proliferative diabetic retinopathy, and this is what we're trying to prevent. Way before this, we should have caught the patient and addressed it, etc. But because diabetic is essentially an epidemic and becoming more and more common, we see more and more patients with severe complications or advanced diabetic eye disease nowadays. There are four main ways that we treat diabetic retinopathy. The first is like anything in diabetes, ensuring good blood glucose control. Now, controlling your sugar is not going to reverse all the damage because normally by the time that you have these kind of complications, you've had poor control for many years. But controlling the sugar helps to prevent further complications, so that's a critical step always. The main thing we want to do is we need to do PRP laser. So this is when we laser the retina. And essentially the idea is we sacrifice part of the retina. So we laser part of the peripheral retina, which is less important. So the amount of oxygen that is available for your macula is enough to prevent it from continuing to proliferate. And so we call this laser PRP, or pan-retinal photocoagulation. So we perform PRP laser, and if we are able to perform this laser early on when we can see the patient starting to proliferate, that normally halts the disease. Most of the time, after you've had laser, the retina settles down, the blood vessels stop growing, and the complications stop. But the problem is, often patients get to us too late, where it's difficult or impossible to perform laser PRP. So laser PRP we can perform as an in-room procedure. So in the consulting room, we've got a machine, we dilate the pupil, and we can laser in the rooms as an in-room procedure. But often patients present to us too late, and what that means is they've had other complications. They've bled into the eye. They've already got a detachment. There's traction. We can't apply laser. We can't see into the eye. We can't see through the blood to be able to perform the laser we need to perform. And so if you can't perform laser, then you can't settle down the disease. And that's when vitrectomy surgery comes in. this is a normal healthy retina. This is what one would expect from a normally healthy retina. As I'm going to show you some examples of severe diabetic eye disease which require surgery. So here's one example, and you might say, well, I can't see anything there, and that's the point. This is an eye that's had a dense vitreous hemorrhage, which means they've bled into the gel of the eye. And this means we can't see the retina. One can't perform laser, one can't see into the eye, one doesn't really know what's happening behind this. We can perform ultrasounds, and sometimes OCT scans can get through dense hemorrhages, but still we can't really see. Sometimes this will resolve spontaneously, but if it doesn't, one needs to go in, remove the gel, and so that one can firstly see what's happening on the retina and then also perform the laser. When we do a vitrectomy surgery in diabetics, we can laser at the same time. So the main goal is to do laser, to perform a PRP laser to settle the diabetic retinopathy down. But if it's bled and you've got a vitreous hemorrhage like this, you first need to remove that blood so that one can see enough into the eye at surgery to perform the laser. Here's an example of a patient who has got a hemorrhage, but as well as tractional detachment. You can see the retina is lifted up, it's being pulled up, and there's all the scar tissue and what we call fibrovascular complexes. So this eye one can't perform laser in. The retina is detached, you can't laser it, and there's already lots of traction that is starting to pull the macula, which is the most important part of your vision. And so one needs to remove the gel, do a vitrectomy, release the traction, release the scar tissue, and perform laser. So this is another tractional detachment or traction threatening the macula is another indication for vitrectomy surgery in diabetics. Another indication is a subhyaloid hemorrhage or premacular subhyaloid hemorrhage. This is a large area of blood. It hasn't bled into the gel, it's bled just below the gel, and this blood is sitting up against the macula. So one again would need to go into the eye, remove the gel, remove this blood, and then perform laser. So what does laser look like? This is what laser PRP looks like when it's just performed. And this is really what we're wanting to perform. If we are able to get good laser into an eye, most of the time the diabetic retinopathy settles down. So this is fresh laser. After a while, these lasers will scar and become more dark or pigmented. So here you can see a few weeks later, these laser scars that have been applied start to pigment, and this is what laser looks like after a while. We leave the macula free, so this part here is an area that isn't lasered, because this lasering this area would affect the central vision, the central 30 degrees, which is your macular area. So your macula is not lasered, the peripheral retina is lasered, and that laser helps you settle down the retinopathy. Now that laser has a consequence. Your peripheral vision, you lose a lot of your peripheral vision. Your night vision is much poorer because this part of your eye is responsible for night vision. It's very good at dark adapting. And very occasionally some patients can even lose a line of vision on the chart. But most of the time that doesn't happen. And without this laser, this eye will continue to progress, and the diabetic retinopathy will get worse and worse. So it's a critical management of diabetic retinopathy. The last thing to mention is that diabetic retinopathy can be treated with intravitreal injections. And this is when we inject medication, anti-VEGF agents like Avastin, Lucentis, Eylea, Visiq, Vabysmo. There's a variety of them in the market that help to stop bleeding. So these intravitreal injections, they do work. They do help stopping diabetic retinopathy, but it's temporary. If you inject, depending on the agent, it normally lasts about a month. After a month, you need a repeat injection. So you have to continue having injections to keep the disease under control. So laser is a permanent solution. Once you've lasered a diabetic eye, normally it stabilizes. If you're injecting, you have to continue injecting every month. Also, intravitreal injections for diabetic patients that have traction, where they've already got parts of their retina being lifted or pulled up or some scar tissue, injecting those patients can be dangerous because often in doing intravitreal injections for these patients causes that traction to worsen. And if it worsens, it can actually pull the retina off or cause or form new holes and can convert a tractional detachment into a combined detachment, and that can be can result in worse visual outcome and more difficult to treat. So yes, intravitreal injections do form part of the treatment for diabetic retinopathy, but it's not the mainstay. Laser is definitely the mainstay, and surgery in cases when we can't laser the eye, there's already traction or bleeding in place. It's important not to confuse diabetic retinopathy with diabetic macular edema. It's both caused by diabetes. Diabetic macular edema is swelling of the retina. Now, diabetic swelling we treat with intravitreal injections. So if you're diabetic and you're receiving injections, it's likely because you have diabetic macular edema or swelling on the retina, and that requires injections. Those injections do help with that. But for retinopathy, where you've got new blood vessels, bleeding, traction, and detachment, all those need to be treated with laser and potentially with surgery. So that's diabetic retinopathy in terms of vitrectomy surgery and advanced diabetic eye disease. I hope it was helpful and interesting, but if you require any more information or you have any questions, please reach out to us and we'll see if we can help.